Okay, welcome to SNU Cath Lab. We prepared the second case in the afternoon that will be treated with Evolut Pro. My co-operator is Dr. Cheong-Kyu Han and Dr. Hak-Seung Lee and Dr. Ji-Hoon Kang and Young-Min Kim, Ha-Hyun-Woo, a specialist from Medtronic Company, and Dr. Hyun-Jung Kim as echo, and Dr. Yeon-Jung Cho for anesthesia. Slide, please. Okay, 79 years old female with dyspnea, function class 3, severe AS with moderate MS was diagnosed. She refused surgery, plus age, old age, and diabetes, hypertension, hypercholesterolemia, renal impairment, and she has already pacemaker due to complete AV block, DDD type, plus severe AS will be treated by TAVI using Evolut Pro. Creatinine is 1.4, GFR is about 40, plus surgical risk is low, 3.7%, plus chest X-ray, we can see the permanent pacemaker. ECG, pace rhythm is normal, plus the function is good with localized abnormality, probably due to pacing, plus valve area is 0.6, mean gradient 50 total, plus whole aorta and iliofemoral artery looks good, plus right, good, plus good, left, plus both renal arteries good, aortic arch is clean, clear. Annulus size is 21 plus 0.5 millimeter without calcium, plus LVOT 22.3 millimeter, similar size without calcium, plus left leg calcification is minimal, balanced, plus the coronary height on the left side is low, 7. Right is okay, 13. Plus sinus valsalva is not wide enough. Left 27, right 26. As the junction size is about 26 millimeter without calcium. Plus annulus to membrane septum length is about, infraannular membrane septum length is about 6 or 6.5 millimeters. It's good, but she has already permanent pacemaker, thus this is not an issue for this patient. Plus, best angle, traditional 3 cusp coplanar view is LAO caudal, and cusp overlap view is RAO caudal. Plus, size of peripheral artery is good. Plus, to summarize measurement of dimension, annulus is 21.5, perimeter 70 millimeter, area 374 square millimeter. As the junction is greater, LVOT is similar to annulus size. Coronary height is low at the left, 6 or 8 millimeter. Sinus valsalva on the left side is 27 millimeter, which is less than 30 millimeter, a kind of cutoff value. As the junction height is low on the left, 14 millimeter at least. And right is 16 millimeter, as the junction diameter is 25 or 26 millimeter. My personal cutoff value of ST junction height and diameter is 15 or 24 millimeter in case of Evolut Pro. I will explain in the later slide. Plus, when we consider Evolut, perimeter is 70, that corresponds to 26 millimeter valve. Oversizing index is about 16%. It's acceptable. Plus, when we consider Sapien, area is 382 square millimeters. That corresponds to 23 millimeter valve with 6% oversizing, but we can adjust it up to 12 by 1 cc overfill. Plus, I prepared 2 issues, how to select valve between the two. The second issue is coronary obstruction. she has at least 3 factors among 4 predictors of coronary obstruction: coronary height, sinus valsalva space, presence of calcium chunk on the leaflet, and S-junction height and diameter. That is not well recognized until now as a risk factor for coronary obstruction. Plus, regarding the first issue, how to select valve, I selected Avalot Pro because of the following rationale. She has already permanent pacemaker. She has a low coronary height, mild calcification with less chance of leakage. Thus, we can choose Avalot. Furthermore, oversize index is acceptable, 16%. Plus, how is the performance of this valve in low surgical risk patients? This is the results of Avalot low risk RCT. All-cause death or disabling stroke for 2 years was about 4.3% in TAVI, while more than 6% after surgery. Plus, how about hemodynamics? Until 2 years, valve area is wider after TAVI, 2.2 square centimeters, significantly wider than 2.0 after surgery. Pressure gradient less than 10 torr, whereas more than 10 torrs after surgery. Thus, Avalot performance in low surgical risk patients is good. Plus, how about issue 2, coronary obstruction during TAVI? The first, coronary height, and second, sinus valsalva space. In this paper, they compared several measurements between patients with coronary obstruction on the left side and control patients on the right side. Sinus valsalva diameter was less than 30 in left side, more than 30 on the right side. Left coronary height, less than 10, around 10 or less in left side, more than 10 on the right side. In these patients, coronary height on the left side is 7, sinus valsalva 27. Thus, there is a higher chance of coronary obstruction. That's the reason why I chose Avalot. On the left side, you can see the incidence of coronary obstruction with Avalot is 0.3%, while Sapien, 0.8%. Plus, regarding the S-junction height and diameter, we always neglect it because there is least chance of S-junction isolation during TAVI. But I just erase the issue here. My personal cutoff value of S-junction height in Avalot is 15 millimeter because the most height of outside skirt is 40 millimeter in Avalot, even in greatest size. Thus, S-junction is above 40 millimeter or 15 or more. There is no chance of touch between S-junction and outside skirt. Plus, regarding the S-junction diameter, as you can see, even the biggest Avalot 34, the waist diameter is 24 millimeter. Thus, if S-junction diameter is more than 24, there is less chance of isolation of S-junction by touching with valve frame. Plus, thus my procedure plan for this case is twofold. The first, I chose Avalot Pro 26 millimeter valve and try to do deeper implantation, considering low coronary height during TAVI to avoid coronary obstruction. After TAVI, to facilitate coronary accessibility. Second issue is coronary protection. She has several risk factors. Thus, I do predilation with 18 millimeter balloon and check coronary obstruction or S-junction isolation. I'll do coronary protection with guiding catheter with insertion of wire and 3/0 balloon. That is the presentation slide.
Okay, Dr. Kim, we would like to have a discussion time about your cases and your treatment strategy. Any comment or question from the panel? Dr. Finkelstein?
그것 좀 불러줄까? 비디오, 플로로.
I think, Dr. Kim, can you hear me?
Yes, of course. Keep going.
Yes.
I think truly this was really a phenomenal explanation and introduction of the case on any aspect. You know, I'm not somebody who doesn't talk. I got nothing to add here. Really, he overviewed any single point of the case, and I can just wish you good luck in this case, and I trust you. But it's really beautiful what you presented.
Thank you very much for your compliment.
Okay.
Professor Kim, just one quick comment. This is Sai here from India. It's so nice to see you, Professor Kim. We missed having
Who
you
is
here.
it? Ah,
Dr. Sai
Satya.
Satish. Hi.
Okay.
yeah.
But that was
You look great.
Thank you. But like Dr. Finkelstein said, that was the most immaculate pre-TAVI presentation I have heard to date. I mean, even the fact that you're planning to go to LAO cranial, do the 18 predil, take a 26 valve, which needs 27 sinus, every single step meticulous. It was a pleasure to listen to it. Again, I wish you all the best.
Thank you very much. Yeah, thank you very much.
Okay. Actually, your presentation is the only focus in the aortic valve, but we have to take care of the other factors. What I mean is that the patient has a chronic kidney disease and the renal function. EGFR is the elevate, so please show us the TAVI procedure, take care of the other factor.
Okay. Let me show you the orthography. This is a caudal view, traditional coplanar view with the three cusps on a single plane, plus cusp of overlap view is ariocaudal. So actually, we use this projection angle during active deployment process. Plus, then we introduce sheath, plus, and we introduce the wire into LV. Where is 0.6 square centimeters, plus, then introduced wire, plus, then we introduce the left guiding catheter and wire, not yet balloon?
Not yet.
Not yet balloon, okay. We are going to insert balloon to more stabilize the left coronary artery guidance protection.
What is your preferred method for the coronary protection? Just a wire, balloon, stent, and guide extension?
Wire and balloon catheter.
And then will you do the predilation?
Yes.
Okay. I'd like to want to know about the total contrast volume in the whole procedure at the end of the TAVI.
다시 그거 해주고.
Dr. Kim, we need to do the valve inspection.
Okay. Valve inspection.
And go to the right side of the lung.
Good. No problem.
The occurrence of the
No answer.
coronary obstruction, actually the incidence is rare, but it occurs. Is a real the catastrophe.
Okay.
So the principle is
말도 안
first one is try to the prediction, and there is some suspicion or the possibility, and then we do try to prevention by the coronary protection, even though the possibility is small. So some of the interventions, most of the cases we will do that without the coronary protection, even though risk of it. But you know that among the 100 or 200 of it, the one case of the coronary obstruction is a real painful. So always try to avoid any minimal risk of it. So that point of view is the coronary protection. This is the high risk of the coronary occlusion by the small sinus of the Valsalva, less than 30, and the low coronary height. So Dr. Kim, even though the coronary protection with guiding with the balloon and wire, and then second step is a check of it, the possibility of the coronary obstruction with a predilation is the adequate treatment strategy. The disadvantage of it is actually this patient is the diabetes and the chronic renal disease, so there is a possibility of the use of the more contrast.
왜 잡았어? 그렇게 뭐야 저 torture 싸울 타네. 와이 잘 잡아야지. 와이 들어가니까 저렇게 비팅 많이 되잖아.
So, Dr. Hong, when you perform the pre-ballooning to check the coronary
Plan of view.
obstruction,
다 나오면 18분.
so
Best angle.
the pullback of the catheter is recommended.
프레쉬
right?
괜찮죠? 자 들어갑니다.
Will you do the angiogram during the predilation?
Of course.
Okay,
So by
I already
pigtail
presented
or
in slide.
left guiding catheter?
okay, excellent.
테스트. 오케이. 자 물론 하면서
제가 이따가
그 다시 쏘면 됩니다. 자 인플레이션 저 페이싱. Inflation, die, deflation, facing off, 저장하고.
After the removal of the balloon, could you play the aortogram during the predilation? Let's check it once again.
오케이.
Replay it.
오케이. 마이너스. 오케이.
Dr. Finkelstein,
Yes,
what is the
junction,
image, the angiographic finding? What is your expectation? And the coronary status is the excellently protected or not?
뭐하노? 아주 빨빨 하지. 인라인 씻어야 되는 거야?
I got to admit that I don't know how
자
is the
뺄게.
transmission in Korea or wherever you are, but I see everything very delayed and in very slow motion.
Sorry.
And I truly cannot appreciate the images of the injection, which in this case, like Dr. Kim said, it's very helpful to see the behavior of the leaflets later on in the implantation. But I truly cannot appreciate. I see the balloon inflated. I
온라인
cannot see.
맞추고. 자 wire stay.
I'm sorry.
My personal point of view is that the angiographic appearance during the
누가 했노 이거?
balloon dilation is that the actually maybe the possibility of the coronary occlusion might be lower. I did not find any something wrong.
밑에 보자.
So
아이, 멍청하네.
so far everything is good.
Yeah, but as Dr. Kim mentioned, there is no problem to implant the valve 6 and more millimeter depth since she has a pacemaker. And if it's a 6 millimeter depth, then the risk of
올라가자.
coronary obstruction is much, much lower.
Why stay? 원래 이렇게 그게 있었어.
I just want
Resistance
to
있었어.
have one more comment regarding the implantation view. Can I?
Of course, keep going.
Dr. Kim,
Leo.
you mentioned the cusp overlap. You know, the cusp overlap is very, very inconvenient for the operator to implant.
Yeah.
But the
자,
main
내가
reason to
트램프로
use
할
it
테니까 why
is in
stay하고.
order to have high implantation and to see the opening of the LVOT, etc., etc. I think that in this case, when you intend not to implant very high, the cusp overuse got no advantage whatsoever, just very inconvenient to the operators. So I think you should use the three cusp view or whatever you wish.
You mean that this case is the conventional co-prana view is the more useful rather than the cusp overlap view, right?
Of course, of course.
다리 좀 채우고. Okay. 자, I made the head marker outside by rotating a little bit the whole system. Then I will advance the catheter around the aortic arch. Okay. Best angle. 그게 잘 안 보이네. 자, 테스트.
Should
저기 그거였나? Okay, I'm going to introduce the whole delivery system and cusp overlap view. 올리려고 했는데 왜 로우야 지금? Okay, cusp overlap view. While staying. Testing. Okay. This cusp overlap view is not good because we can see the head marker is not single line. But anyway, I will deploy the system a little bit, change the original angle. 영민,
오리지널 앵글로 원래 앵글.
company's recommendation. 카우달, 이게 company recommendation이야?
This is
Okay.
some limitation of the cusp overlap view. When you look at the valve, there is a
Testing.
too crowding of the valve, caster,
Okay,
in the point
deploy.
of the interest.
deploy,
That is some limitation of the cusp overlap view.
deploy.
Stop. Test.
BP가 좀 낮습니다.
Deploy.
deploy,
Deploy.
deploy, deploy, deploy.
Stop. Test. 혈압이 낮아요. Okay, deploy.
And when you look at the alignment of the caster and the ascending aorta, is not parallel.
저장하고. Deploy.
deploy, 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 deploy.
Stop. Deploy 하면 한 번만 해. 이게 반정교하고 정말 1년 만에 하니까 그게 안 되네. 자, 테스트. 오케이. 저장. Deploy. Stop. Deploy 하면 한 번만. Deploy. 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 Stop. Test. 오케이. Deploy. Deploy. 저장하고요. Deploy. 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 Test. Good. Deploy. Deploy. deploy, deploy, deploy. 쭉 가면 됩니다. 더 끝까지 가야 될까요? Stop. Test. Okay, this is my intentional depth, a little bit deeper than usual. But as I mentioned before, deep implantation is safer in terms of coronary obstruction, and deep implantation is good for the future coronary access for the patients. Okay, T가
I
있나요?
agree.
확인하겠습니다.
I will introduce the TE.
Please comment about the echocardiographic finding.
This is the 45-degree view. You can see some paravalvular leakage around the valve.
Around the valve. 12 o'clock and
The
6
emerging
o'clock.
point is probably 1 o'clock. That swirls down,
Okay, so far it's good.
and the paravalve leakage assessment is not useful before release of the valve because the uppermost part is captured in the sheath. Thus, such kind of feature is not maintained after release.
Okay, we are
Okay,
waiting.
how about the depth? Hinges.
Yes.
Okay.
In a longitudinal axis, the distal margin of the stent is quite reasonable and appropriate. Does not interfere
Okay,
the mitral
let me
valve
check the
motion.
coronary flow.
3시까지입니다.
There is considerable paravalvular leakage.
coronary flow. 자, 쓰네.
네.
준비됐어? 오케이. Okay, just 앵글을 좀 바꿔볼까?
I think if
I-
you deploy
I
the valve, the coronary flow is maintained.
한전수 앵글 알잖아.
The reason why the coronary flow was engaged by the caster, so that with that space is
연결해서
capable to supply the coronary blood flow.
그렇게 카우달이 될 것 같아, AP에서. 훨씬 크라니얼 가야지. 약간 엘레여봐. 조금 더. 크라니얼. 맞나? 맞는 것 같아. 오케이. 자, 이렇게 픽테일이 완전히 휘말려가지고, 그지? 오케이, 자, 여기서 한번 시내 해볼게요. Depth is good, so I start release process.
Agree.
Okay.
We can clearly see some
Okay.
distance from the evolute valve and the guiding of the
천천히
left
해야지.
side.
아, 참. 좀 기다렸다가 하고 해야지. 아무리 in depth라고 하더라도. Release.
I expect that after the deploy of the valve,
Release.
I think a coronary flow in this patient is the
Release.
excellent. That is my
Release.
betting.
Release. Release. Okay, full release. Okay. Okay. Y stay 빼고. Y stay. 자, capture.
In these images,
Okay.
even though after the valve deployment, there is some distance, clear distance between the left guiding caster and the valve. It means that the possibility of the obstruction is very, very low.
I introduced the wire and removed the pigtail a little bit.
어디라면 어디야? 맞죠?
여기?
네.
몇 개 갖다 놨어?
I just retrieved the left guiding a little bit outside to directly see the left main ostium.
다이치.
T를 언제 볼까요?
At this point, I would like to repeat the root arthrography. Wire is biased. Okay. Snap, please.
Excellent.
Yeah, coronal ostium is preserved, so we can remove the Jitkin guide catheter. Okay, we are going to withdraw the valve system and change to the, okay.
This is a very nice
Wire
demonstration of the severe aortic stenosis patient with a low coronary height and the lower size of the aortic annulus.
저쪽이야.
This kind of patient is a more predominant in the Asian patient rather than the Western patient. The patient is like the 79 female patient. Is an elderly female patient. This kind of feature is shown usually in the 20 to the 25% of all our procedure. Is quite common in the Asian patient. So, how do we fix it? This kind of patient Professor Kim shows that is the use of the self-expandable valve. The operator has a very comfortable feeling during the procedure.
좀 22면 돼요? 준비해 주세요. 네, 준비해 주세요. 이걸로
We can clearly see the space between the coronary ostium and the valve.
Why stay? Okay. 자, 픽테요.
피기테일. 피기테일.
T요. T 소개.
T 빨리 해야지.
네. From the 45-degree view, we could see a small remaining paravalvular leakage around 6 o'clock.
T를
as you can see here.
보여줘야지.
나오고.
다시 repeat 해봐.
Please show us a more bigger image and the parasternal long axis and the short axis.
AP.
Color.
Color.
describe를 하라니까 describe를.
You can see some paravalvular leakage around 12 o'clock.
Yes.
And
What is the severity?
that is the main. I think
Mild,
around
moderate,
mild.
mild.
Yes, mild
Okay.
to moderate, mild, around mild. And we'll go to the 135-degree view.
Okay.
You can see paravalvular leakage at around the 12 o'clock view.
Okay. Based
I
on
think the
that,
severity would be around mild to moderate.
we need the additional post dilation or not?
After angio.
Based on the
hemodynamic
T
measurement.
finding.
T 한번 보여주지.
피포컬.
T를 보여주라고.
This is the T view.
누가 있노? 황도영 좀 제대로 못해? 아이 참.
나오고 있습니다.
There is a mild to moderate, yeah, substantial amount of leakage. I think, of course, 16% of our size index may be insufficient. Okay.
So, Dr. Kim, you will do the
Okay,
additional
pressure.
dilation?
No, not yet.
Okay.
Please wait.
Okay.
Can you see the pressure profile? 뭐가 안 맞는데 저기 너 다이크로틱 너치가 안 보이잖아. 예? 좀 플래싱 좀 잘해봐. 야 강지훈 들어와야 되는 거 아니야? 예? 그걸 받아. 이게 뭐야? 아울타야?
이게 어때?
그런데 뭐 저렇게 그거 하노? 안 보이노? 이게 3웨이가 또 그거 하나? 에이씨. 3웨이 딴 거죠? 이지 멍청이들 진짜.
이거 R3.
이때 뭘 보여주노? 엔지오를 보여주면 되잖아. 왜 저걸 보여주니? 재미없는 엑셀 파일을 왜 보여줘?
이런 거 싫어.
황도현 제대로 안 해?
이런 거 싫어.
자산기에 왜 저 엑셀 파일이 들어가 있어? 답답하네 정말. 다시 플래시 할게. 근데 we have to wait for the time. Wait for the leakage may decrease by continued expansion of valve leaflet, valve frame. Meanwhile, we always check the pressure profile.
Okay. So far, your procedure is so excellent to show us the nice coronary protection in the high-risk patient.
Okay, systolic blood pressure is about 130, 135, 130. Diastolic notch is about 80, 80. Diastolic pressure is 58, LVDP 20. Another call, systolic blood pressure is 130, 130, diastolic 78, diastolic 56, 57, LVDP 18. AR index is around 28 or 30. New index is about 5. That suggests leakage should be very minimal. Okay, we are going to check the angio.
Dr.
Hemodynamically and
Kim, you are
also
doing,
Dr. Finkelstein,
sorry.
keep going.
if you are doing another angio, which is wise, do
Of
it
course.
without the stiff wire
야,
in the
강지훈 들어와.
because it is truly exaggerating the leak that we cannot appreciate which one is intravalvular and outer. I think that your weighting is smart, and according to the tracing, the hemodynamic tracing, it looks like it's gonna get better and better.
Most of the cases was done the angiographic guide, but as you see, after the TAVI procedure, in the angiogram looks like a very severe
Okay.
the
스냅.
aortic regurgitation, but the hemodynamic status is not so much, and the transesophageal echo echocardiographic finding is minimal. So it means that there is the discrepancy of interpretation of the angiographic finding and the echocardiographic finding. So what we should choice determine which one is really reliable. Personally, I choose the echocardiographic finding rather than the angiographic appearance. So personally, I think so far the Dr. Kim's procedure, hemodynamically AR index more than 25, and the transesophageal echocardiogram
Okay,
is
let me speak. Yeah, Dr. Hong,
small.
let me speak. You are too
Okay.
much. Okay, let me introduce the data. Once again, AR index 28 and 30, new index 5.2, 5.3, meaning no leakage. Then angiogram with guiding pigtail catheter in situ, as you showed, there is no regurgitation. Then at this point, we are going to see the T.
T. On the T, first I'll go to the 45-degree angle.
Is very subtle leakage at 12 o'clock, not
Yes, there is a leakage. The main point is at the 12 o'clock.
negligible, artifactual.
Just a minute. The main point is around at 12 o'clock. It's around mild, I think. And then when we go to the 135-degree angle, you can see a mild paravalvular leakage from the same point.
그거를 좀 줄여봐. 그 게인을 엄청나게 브라이트하게 하네. Okay, I think the echo finding is exaggerated. Yeah. Then I'm going to remove the left guiding system because we are sure that coronary obstruction will not happen. Okay, I can show you the other projection root arterography to make sure a little bit discrepancy between angio and echo and hemodynamic data. 약간 AP 연저리로. 맞나? Okay. At this angle, I would like to repeat the root arterography. Cine, please. 다이 준비하고. Shoot. Nearly negligible regurgitation with optimal depth. I try to maintain the coronary height after TAVI valve implantation. When you implant TAVI valve a little bit higher, the neo coronary height should be about 1 or 2 millimeters. Thus, it is impossible, very difficult to engage coronary artery in the future. Thus, I try to maintain the depth of implantation. I think the depth would be 6 millimeter or how about 7 millimeter? 전혀 참여 안 하네. Plus. Okay, coronary flow is no problem. Once again, echo.
Yes.
해볼까? The pressure profile is good. Pulse pressure is not wide, but echo is too sensitive. Echo tells us there is a moderate degree regurgitation, but actually hemodynamics, pulse pressure, angio, negligible.
Congratulations. Personally, I am happy about your procedural result. so far.
The
I think it's a very nice result.
Regurgitation happens just between the non-coronary cusp and left coronary cusp. But when we see the CT, slide please, CT slide. CT slide, 칼슘. 그러니까 슬라이드 확보하고 컨버전 해야지. 답답하네. 자. Okay, 다시. Yeah, we can see there is a kind of dot calcium at NC at the commissuring point between LC. Thus, there is a subtle calcium dot at the commissure of NC and LC, just one side, on the NC side, but that may cause really trivial leakage. But that are exaggerated in TE because of elevated gain. T once again. T 다시.
네. You can see on the T on the 45-degree view, on the short axis view, you can see a point of paravalvular leakage at around 12 o'clock.
That is between non-C and LC. Thus, a subtle calcium dot at the commissure point may lead to such kind of trivial, although it is trivial, leakage. Thus, calcium amount is important, but more important is calcium location. Edge, body, no problem. Commissural calcification is a very important predictor of leakage. 여기서 보면은 마이트럴 스테노스 플로우가 너무 세가지고 지금 잘 안 보이잖아. 예? Okay, angio again. 슬라이드 대신에 자상기에 뭐 헤모다이내믹스. How about the depth of implantation? The specialist decided that the implantation depth was 7 millimeter on the non-coronary sinus and a little deeper in the left side. In the left side, how much? 9. 7 to 9. %, oversizing index may be insufficient in case of ugly annulus, but in this case, annulus is very clean. Thus, even though a little bit insufficient oversizing index leads to complete blockage of leakage, although there is a little trivial leakage at the commissure between NC and LC. Minus.
In my eyes, the depth of the stent, the valve is in the non-coronary cusp looks like just 5, and the non-left coronary cusp is about 7. You know that in the contrast staining in the lower part is very faint. It's not. I think it's not so low.
In this view,
the important is that the angiographic interpretation is very, very difficult and variable. So at the time we do the TEE and then try to find what is the functional problem. If there is no limitation of the mitral valve, that's it. Why not?
How about the impression of this case, Dr. Finkelstein or Sate?
First of all, I think really, Kim, you know, I don't have to flatter you, but 10 years ago, I was your proctor. I think you can start being my proctor. I mean, you've done a wonderful job. There's nothing to add here. I have only 2 comments. One is that if I noticed you, in some parts of the implantation, you implanted the valve with your left hand and you control the wire with your right hand. Am I right? I mean, are you
Yes.
the only control freak more than me in the world?
Because I always insist the first operator should manipulate simultaneously sheath and wire.
Yeah,
Thus,
we call
if
it comfort freak. We just call it
Yeah, yeah.
comfort freak. And second, you know, I'm bald, and you have more hair than I used to have when I was 30, and still I'm wearing a hat in the cath lab and you don't.
뭐라고?
But I got no comments, really a perfect implantation, beautiful. And I think that your injection in the RAO position, in order not to see the so-called AI on the background of either the aorta or the spine, shows us that there is minimal AI.
Agree.
How about the opinion, Sate?
As usual, Professor Kim, picture perfect implant. I think this is a frail lady. She's sick. She's got some renal dysfunction. You have a great AI index. The jet could look exaggerated in the echo because of some anemia, hyperdynamic circulation. I wouldn't be too obsessed about it. Diastolic pressure is good. Fluoro looks good. AI index looks good. I think it's a great case. I love the way the valve tilted a little more to the left than to the right, but I think it's a beautiful implant and I think it's a great result.
Okay, let me show you the hemodynamics before and after TAVI. Before TAVI, great pressure gradient. That suggests the LV contractility is good. In this case, always the prognosis after TAVI is wonderful. Some guys fear about high pressure gradient, but for me, I'm really pleased to see such kind of high pressure gradient because it suggests this patient's LV function is wonderful. And after a procedure, some patients show elevated LV EDP. That is immediate poor prognostic sign, but in this case, LV EDP is stationary and less than 20, same before TAVI. Thus, I expect this patient's recovery is really bad, the best. Before TAVI, the patient shows a moderate AR, suggesting here AR index is 31, but new index is 3.2. The cutoff value to determine the significant leakage is 4. The C is less than 4, even though old index is 30. After TAVI, AR index the same, 30, but new index different, more than 5, suggesting no leakage. Well correlated with the pressure profile.
Okay. Any other comment or question about Dr. Kim's procedure? Question?
Thank you for Dr. Kim. Very excellent case and educational
NGO.
case. In such case, if we need the post-dilatation, during post-dilatation, we can remove the protection LID guiding catheter. We can after remove post-dilatation or before remove post-dilatation.
Definitely after, before I do a post-deal before removal of LV guiding catheter. Removal of LV guiding catheter should be the last procedure because after post-ballooning, there may be additional change around frame and left main ostium.
We have a 3-minute discussion time. Dr. Kim, 원장 Kim, any comment or question?
Yes. May I have a question to the very quick question? Do you usually the coronary protection by using the balloon or stenting? But sometimes it's balloon is very useful. However, in kinking during the stent strip, the coronary is very digested. What is your some routine practice in your cath lab?
I have many cases of coronary protection with insertion of guiding catheter. Old cases, ended without intervention of left main. Thus, my principle is to engage balloon catheter, not stent, because if we engage stent, it is discarded and not reimbursed. Thus, to save the money, I always insert balloon catheter, cheaper than stent.
Personally, for the purpose of the saving of money, I prefer the guide extension rather than the balloon.
I have
Yes,
one
that is
simple
a
question.
good option.
I
But
have
in
one
case
simple
of narrower left main or LAD, I hate to introduce deeper another catheter into coronary artery. Thus, I don't use extension guiding catheter to protect left main or LAD.
Okay, Dr. Lee, Cheon Lee.
Okay.
Yeah, I am Charani. Thank you for your excellent case and good results. Simple question. This case is right femoral puncture is acute angle slightly. When puncture the femoral artery where main device will enter, do you prefer sono-guided puncture or roadmap angiography guided puncture in TAVI?
No, just we follow the traditional fluoroscopic angio-guided puncture. But we all acknowledge the three-dimensional course of common femoral artery by pre-CT angiogram.
Okay, Dr. Kim, it's time to close, and congratulations. Your case is very educational and informative, very useful content in your TAVI procedure. Congratulations again. Thank you.
Okay, thank you very much. See you next year.